already got many accolades regarding a visiting faculty at Savita University. He is also the EB West Zone IAP Allergy chapter member, and he has contributed a lot to the site, especially to the module on anaphylaxis and allergy. He has got an immense contribution. So we are very fortunate that Dr. Vikram is with us today as an expert to discuss the case. Dr. Radhika Kedia, she is the DNB trainee. She will be presenting the case from Sir Gangaram Hospital. So Dr. Radhika, you can please start. Dr. Vikram,
Thank you,
you
sir.
can stop her anywhere in between and you can discuss wherever you feel appropriate.
Yeah, sure.
Okay. Dr. Radhika, please start.
Thank you, sir. Good evening, my colleagues and dear seniors. We today will be we'll be discussing a case of anaphylaxis that presented to our emergency room. So my patient was a 12-year-old male belonging to Patel Nagar, Delhi. He presented to the ER on 3rd of July, and the date of examination was 4th of July when he presented to the OPD. He presented to the ER with complaints of generalized rash and itching for 30 minutes and difficulty breathing for 20 minutes. History of presenting complaints: the boy was playing cricket 30 minutes back when he developed rashes that appeared throughout the body, which were erythematous, gradually progressive in size, and were raised. They were associated with itching. They were not associated with any burning sensation. He also developed difficulty breathing 20 minutes back. The boy had consumed dinner, which included chicken, mutton, and prawns with wheat rotis, following which he went to play cricket with his sibling on the terrace. He developed these symptoms within 10 minutes of playing and around 1 hour after dinner. Negative history: there was no history of wheezing, noisy breathing, or chest pain. There was no history of bluish discoloration. There was no history of vomiting, nausea, loose stools. There was no history of collapse or lightheadedness. There was no history of insect bite. There was no history of consumption of a new food group. And there was no history of fever or arthralgia. Past history: there was no history of severe allergic reactions in the past. There was no history of allergic reactions in the past after consumption of wheat, prawns, chicken, or mutton. There's no history of allergic reaction after exertion. There's history of allergic rhinitis. Child is not a known case of asthma and he's not on any medications.
Dr. Radhika, I would interrupt here.
Yes, sir.
Yeah, I would like to ask, can you just elaborate allergic rhinitis symptoms in him? Since when they are observing allergic rhinitis?
So the child developed symptoms of allergic rhinitis around 3 years of age. They noticed that he would have nasal congestion in it was an annual variation in symptoms.
Perennial, you meant to say?
Yes, sir.
Okay. Then you mentioned that the child had all these problems when he ate or after dinner, he went for playing, right? But he didn't consume anything, any new substance he consumed, any new food items he consumed this time?
No, sir, he had not consumed any new food items. These are all things he had had in the past.
Fine. Please proceed.
Family history: the child is born to a non-consanguineous marriage. The sibling also has atopic dermatitis. Antenatal history was normal. It was a case of book pregnancy. Mother received iron and folic acid supplements. 2 doses of TT were received and antenatal scans were normal. Birth history: the child was born by LSCS indicated due to CPD. It was a term pregnancy. Birth weight was 3.06 kgs. There was no NICU stay after birth and breastfeeding was initiated within 24 hours of birth. Diet history: breastfeeding and top feeds were given till 6 months of age. There was a calorie excess of 20% and protein intake was adequate. The child was immunized according to a national immunization schedule, and there were no history of allergic reactions to vaccination. Family belongs to upper class according to modified Kukuswami scale. They live in a pakka house with clean water supply. There are no pets at home. The house is carpeted and the apartment is well ventilated. There's no use of humidifier at home. Coming to general examination, there was no pallor, icterus, clubbing, cyanosis, lymphadenopathy, or edema. Vitals: heart rate was 90 beats per minute, regular, good in volume. All peripheral pulses were palpable. Blood pressure was 120 by 72 millimeters of mercury measured in the right arm via auscultatory method, which was between the 50th and 90th centile for age and height. Respiratory rate was 20 breaths per minute. Abdominothoracic breathing was noticed. Saturation was 98% in room air, and the child was afebrile.
Excuse me. Yeah. So whatever the vitals you have mentioned on your examination finding, these were the timing at the time of presentation or when you took the history that time?
So these were the vitals at the time of my examination on the next day.
So always try to recollect from the documents, and when you are presenting a case, always try to have the vitals which were present. Now we are presenting not only for as an exam purpose. Here we are going to discuss about the condition, right? So
Yes, sir.
here you are allowed to write the vitals, whatever were present at the time of hospitalization. Okay.
Okay.
Yeah. So do you know what was the blood pressure when the child arrived at the casualty?
Yes, sir. I have that with me. Uh, so the blood pressure was 110 by 70.
Okay. And what was the respiratory rate, heart rate at that time?
So the heart rate was 96 beats per minute, and respiratory rate was 28.
Because you mentioned in the chief complaints, the child had breathlessness also, right?
Yes, sir.
After arterial rashes, the child developed breathlessness.
Breathlessness, yes, sir.
Okay, fine.
Head to toe examination was normal. There was no finding there. Physical examination, coming to the anthro, the height was 160 centimeters, which is between 90th and 97th centile for age. Weight is 60 kgs, which is between 90th and 97th centile. BMI was 23.4. So the child was overweight according to WHO chart. These are the IAP growth charts. System examination, the chest had bilateral vesicular breath sounds, abdomen was soft, umbilicus was central, and there was no hepatosplenomegaly.
So can you describe what was the presentation findings in the system
Yes, sir.
examination? Yeah.
So at the time of presentation in the ER, the child had bilateral wheeze and bilateral expiratory wheeze was there, sir. And apart from that, he had generalized urticarial rashes.
Okay. So there was no stridor and peripheral pulses also very well felt, right?
Yes, sir.
Fine.
Abdomen was soft, umbilicus was central, and there was no hepatosplenomegaly. Cardiovascular examination was normal, and the child was conscious, oriented to time, place, and person. Jesus was 15 and 15, and pupils were bilaterally reactive to light, and there was no focal deficit.
Fine.
So to summarize the case, a 12-year-old boy had come with complaints of generalized rash for 30 minutes, associated with itching and difficulty breathing for 20 minutes following a period of exertion. There was history of meat and seafood intake prior to the exercise. Past history is significant for allergic rhinitis, and sibling has a history of atopic dermatitis. There is no significant antenatal, natal, or postnatal history.
So what are your differentials?
My differential diagnosis, the first differential diagnosis is anaphylaxis. Second is acute generalized urticaria, and third is hereditary angioedema.
Would you like to rule out?
So we'd like to rule out.
What are the points which are suggestive of anaphylaxis in this case? What are the points which made you think about acute generalized urticaria? And what are the points which are suggestive of hereditary angioedema? So that we
Yes, sir.
can reach to a narrow diagnosis.
So the child had generalized urticaria along with difficulty breathing. So that is a skin involvement with a respiratory symptom as well. So that would classify as anaphylaxis.
Okay.
According to the criteria given by World Allergy Organization.
Fine.
So that supports the diagnosis. Sir, acute generalized urticaria, it could be cholinergic urticaria that happened after exertion. So in that, we would see urticarial rashes along with wheeze could also be there in cholinergic urticaria.
No. Cholinergic urticaria, you are right. Rashes will be there, and
Yes.
wheezing will not be there in urticaria. So urticaria means only skin manifestations, right?
Yes,
So
sir.
do you know the difference between the cholinergic urticaria, the rashes seen in cholinergic urticaria, and the rashes seen in usually what and the normal urticaria what we see day in day out?
So in cholinergic urticaria, the rashes would be smaller. The pinpoint urticarial rashes would be present.
Pinpoint, and
Hmm.
severe itching will be there, and within few hours of resting they disappear.
Yes,
Fine,
sir.
fine. And what about angioedema?
So hereditary angioedema, there would be non-pitting, non-pruritic angioedema, and there would be a history of recurrent episodes of angioedema in the past as well. It could also be associated with the family history of angioedema because it is autosomal dominant. So it could.
Now when we talk about angioedema, it can be idiopathic or hereditary, right? Acquired or
Yes.
hereditary. Now, in among the cases who were present to us with urticaria, angioedema can be associated with them. So approximately 10% of urticaria patients can have angioedema also. So angioedema means what?
So angioedema is mucosal swelling of the lips, genitalia region, eyelids.
Yes,
Uh,
dorsum of hand and feet also, right?
yes, a dorsum of hands and feet.
Right. But when you talk about hereditary angioedema, always remember there won't be any urticarial rash. So the child may present to you with all of a sudden appearance of swelling over the lips. Laryngeal edema can lead to stridor, and the child, it can be a life-threatening situation. But never in hereditary edema you will get urticarial rashes. So with all these things, with a genetic predisposition, the child had already allergic rhinitis. There is family history of atopy, and this child had urticarial rash, as you mentioned, as per the criteria of anaphylaxis. So can you elaborate the different criteria for anaphylaxis?
Yes, sir. So the IAP
Have you
in
mentioned
the
in your
IAP,
slides? Have you mentioned
sir?
in your slides?
Yes, sir. It is there, sir.
So go ahead. Go ahead.
Okay, sir. So the treatment, the child was brought to the ER on the day of symptom onset and was administered injection hydrocortisone 100 mg, injection phenylalanine 22.75 mg, and nebulized with adrenaline. He improved symptomatically and was discharged on oral prednisolone, tablet fexofenadine, and Budecort nebulization. The child was followed up in the OPD next morning.
So here we should discuss about the treatment. So why nebulization with adrenaline was given for this patient?
Sir, in the treatment protocol, if the child is coming with stridor, then we can give nebulized adrenaline to relieve this.
But in this case, the child had wheezing, right?
Yes,
There
sir.
was no stridor you mentioned.
Yes, sir.
Fine. And what is missing in this treatment?
So, intramuscular injection of adrenaline was missing.
So I think the resident who was there on duty could not recognize that this could be anaphylaxis, right?
Yes, sir.
Yeah, this is very common mistake being done. And always remember, adrenaline is the first treatment. Later on, you can go for hydrocortisone or phenylephrine, but always the first injection should be injection adrenaline, epinephrine, intramuscular.
Yes,
So in
sir.
the theory part, we'll discuss it. Yeah.
Okay. So coming to the discussion of anaphylaxis, the
Just a
latest
minute.
definition.
Don't, please go back again to the treatment file. Yeah. So he improved session and was discharged. So he was discharged after how many hours?
Sir, he was discharged after 4 hours.
So he was discharged after 4 hours, and then he was called next day. And when you took the history, right?
Yes, sir.
Fine. So here, this point we'll discuss again whether we should discharge within 4 hours or we should keep them for observation. Let us discuss the theory part first.
Okay. Anaphylaxis. According to the latest definition given by WHO in the ICD-11 2019, anaphylaxis is a severe, life-threatening systemic hypersensitivity reaction characterized by being rapid in onset with potentially life-threatening airway, breathing, or circulatory problems, and is usually, although not always, associated with skin and mucosal changes. It was found that in around 10 to 20% of the patients, no skin and mucosal changes were found, and hence the diagnosis of anaphylaxis was not made. So there's delayed treatment.
Okay.
It could be of two types. It could be IgE mediated and non-IgE mediated. In the IgE mediated anaphylactic reactions are the classic and the most common type. They are triggered by the interaction of an allergen, which is usually a protein, interacting with the allergen-specific IgE complex expressed on the effector cells, which are usually mast cells and basophils. In non-IgE mediated reactions, we have immunological and non-immunological reactions. So in immunological mechanisms, this may involve the activation of the pathways such as the complement system, contact and coagulation system activation, or IgG mediated anaphylaxis. Non-immunological mechanism includes the activation of mast cells by drugs such as opioids, NSAIDs, ethanol, and physical factors such as exercise, which may be involved in triggering anaphylaxis directly. Coming to the pathology, this is a severe type 1 hypersensitivity reaction. So on the right, we have the figure where an allergen, usually, for example, pollen or any food allergy, it is coming in touch with the mucosal lining, and it is activating the T helper 2 cells. The T helper 2 cells are activated and they release three interleukins, interleukin 4, interleukin 5, and interleukin 13. Interleukin 4 is responsible for class switching of B cells to IgE. And interleukin 5 is responsible for eosinophil activation, whereas interleukin 13 is responsible for increased mucus production that we see after Th2 activation. So when the IgE secreting B cells are produced, these IgE bind to the Fc epsilon Ri receptors on the mast cells, and they lead to degranulation of the mast cells. So
No, here I
when
will
the mast cells
interrupt. Now the IgE, they go and bind to these high affinity receptors, right? So on
yes, sir.
binding, immunoglobulin getting binded to the mast cells is not going to cause degranulation. This is the, see, you can see from here, that two immunoglobulins are there attached to the mast cells adjacent to each other. Now on re-exposure, whenever the allergen comes again into the body, already the IgE are formed. They are in a bound form to the mast cells. Now this allergen comes, they sit over there. So you can see the cross-linking of two antibodies. So whenever an allergen re-exposure, an allergen comes, they bind to the IgE. There will be a formation of IgE as antibody and allergen complex, right? So that leads to cross-linking. So whenever there is cross-linking of two IgE antibody, you expect the mast cells to get degranulated. So just binding. So even in a normal child also, if he is sensitized, you will find IgE lying over the mast cells. Free IgE is circulating in the blood cells. So free circulatory IgE antibodies are detected in the blood test. We go for serum specific IgE. You get blood test, serum IgE specific. So that is just telling you that the person or the patient is sensitized and IgE are produced. That doesn't mean that the child is having symptoms. The child may not be having any symptom. Just by sensitization, IgE antibodies are formed. Now, when these IgE antibodies are in the bound form to the mast cells, when you do allergy skin prick test, so on doing allergy skin prick test, you may develop a wheal over the skin prick site. So again, that tells you that IgE is produced and that serum specific the IgE is bound to the mast cells. Now, again, still the child may not have any symptoms, but on re-exposure to allergens, the child may develop symptoms. So there will be degranulation, the activation of mast cells. Clear?
Yes, sir.
Yeah.
On repeat exposure to the allergen, there is degranulation of the mast cells, which leads to vasoactive amines like histamine and tryptase. Histamine causes vasodilation, increased vascular permeability, and smooth muscle contraction, and increased secretion of mucus through interleukin 13. Other mast cell content includes tryptase, which may damage the tissues and may also generate kinins and cleave complement components to produce additional chemotactic and inflammatory factors such as C3A. The mast cells also synthesize membrane phospholipids such as arachidonic acid, which leads to the formation of prostaglandin D2 and leukotrienes B4, C4, and D4. They lead to the immediate response that you see after an allergic exposure, which leads to vasodilation, vascular leakage, and smooth muscle spasm. The cytokines are also secreted by the mast cells, and this is responsible for the late phase reaction where there's infiltration of the leukocytes, and this leads to direct epithelial damage and bronchospasm. We'll discuss a bit about the physiology of anaphylactic shock.
Yeah, go ahead.
So there is extravasation of fluid because of the vasoactive amines, and this leads to airway edema. Airway edema leads to bronchospasm and also hypoxia. Because of the vasoactive amines, there is also vasodilation. Vasodilation leads to reduced venous return, and this leads to reduced cardiac output. Reduced cardiac output leads to decreased blood flow to all the end organs. There is reduced pulmonary blood flow, which in turn adds to the hypoxia. There is also hypotension, which leads to inadequate tissue perfusion and inadvertently leads to shock. So here we have the latest criteria given by World Allergy Organization in 2020, where the previous criteria for anaphylaxis had three criteria, and now the first two have been combined to form one cumulative criteria. So now we have any one of the following. If they are present, then we can.
I would enter here. So basically, till 2020, 2019, we were following the National Institute of Allergy and Infectious Disease guideline, where there were three three criteria. Now in 2020, the World Allergy Organization has come out with this thing where the last two they have combined into one. But again, after 2021, when again European Association of Allergy and Clinical Immunology, they come out with a recent guidelines, but again they are still following the previous one. So either can be followed. The main purpose is not to miss a case of anaphylaxis. So here we'll go in detail with for each and every point how to suspect anaphylaxis. Yes, go ahead.
Okay, sir. So, given by the World Allergy Organization, any one of the two following criteria have to be fulfilled. So, the first is there is acute onset of illness, that is minutes to several hours, with involvement of skin, mucosal tissue, or both, and at least one of the following. So, either there is respiratory compromise in terms of dyspnea, wheezing, stridor, reduced PF, hypoxemia. There is reduced BP, or associated symptoms of end organ dysfunction such as hypotonia, syncope, and incontinence, or there are severe gastrointestinal symptoms such as severe crampy abdominal pain, repetitive vomiting, especially after exposure to non-food allergens. Or the second criteria is there is acute
So,
onset of hypotension.
Wait, we'll discuss here. We'll come to here. Now, do you remember or do you know the previous guideline or previous
Yes, sir.
criteria? Yeah.
Yes,
So
sir.
first criteria is that key acute in onset and involvement of skin. The main criteria, like we for any criteria we say major and minor, right? So first criteria is that there will be involvement of skin or mucosal edema, and along with that, any one out of respiratory or circulatory collapse or GI symptoms, right? So
Yes, sir.
this fits into but the previous guideline what they mentioned, even if there is no history of allergy, even if we don't know the dietary history, no triggering factor, but still any patient who comes to ER with urticaria. Now as you mentioned, one of the disease as generalized urticaria. So in general urticaria we will not think of anaphylaxis unless the child has got any other system involvement. Now if a child has got urticaria and along with that there is wheezing, go for adrenaline. Don't question anything. Give adrenaline first and later on you keep taking the history. What was the culprit or what was the trigger? Or if the child with urticaria has come to you with a hypotension or a circulatory collapse, still you go for adrenaline. Or sometimes urticaria may come to you with abdominal pain, but severe crampy abdominal pain with vomiting, refractory vomiting, then you should go for again adrenaline. So urticaria with any of the system involvement, you go for it. That was the criteria one. But that criteria two, when there is exposure to allergen, now known allergen, may not be allergen for him, any likely allergen. So can you, Radhika, mention what are the likely allergens food allergens which can cause anaphylaxis?
Yes, sir. Sir, common food allergens include wheat, peanuts, seafood like shellfish, prawns, or cow milk.
Yeah. So basically there are main 8 common allergens which are responsible for food allergy and subsequently anaphylaxis. First, remember, is the milk. Second is egg. Third is wheat. Then tree nut and peanut. Then fish, shellfish, and soybean. So these are most common food allergens. If the child is exposed to any of these, may not be a known allergen. Allergen means there is no past history of allergy, but the child is exposed to this, or the child had taken some medication, or which can lead to allergies, or there is history of bee sting or any insect bite. So that means the child was exposed to any likely allergen. Then, then the criteria for having urticaria is not a must criteria. I'm talking about the previous criteria. So there, if the child presents to with any 2 of the following four means rash or any of these 3 systemic involvement, then still it is urticaria. So that means the child has consumed something, has come to you with wheezing and severe abdominal pain. Go for adrenaline. Clear? So here you may think, why should we give? There is no urticaria, but still there are two system involvement. Two system involvement is there. Then you should think of, or you should suspect allergy or anaphylaxis in this case. Then the third criteria was, if there is known allergen, means previously the patient was diagnosed to have some allergy. Say the child was having allergy to egg. There was some episode in the past also, and accidentally this time the child has taken egg, and the child presents to you with just hypotension or a circulatory collapse, no other symptom. Still you should we'll go for IV fluid bolus and adrenal and drip or non-adrenal drip later on, but first thing is to give intramuscular adrenaline here. So here in this new World Allergy Organization criteria, the second points, they have mentioned all these points. Please go ahead, Radhika, go ahead.
Yes, sir.
No, mention the second. Yeah.
Yeah. The second criteria is acute onset of hypotension or bronchospasm or laryngeal involvement after exposure to a known or highly probable antigen for that patient, even in the absence of typical skin involvement.
So here they have combined the second and the third criteria from the previous into one.
Yes,
Yeah.
sir. So changes from the previous criteria, the aim is to simplify the existing criteria by combining the first two criteria. Persistent gastrointestinal symptoms have been changed to severe in view of ambiguity in the word persistent. The change was also done to signify that skin signs are absent in 10 to 20% of anaphylaxis reactions, and this may result in delays in the recognition of anaphylaxis. So some common allergens. So we have food allergens like celery, cow's milk, hen's egg, peach, peanut, seeds such as sesame, shellfish, and tree nuts and wheat. Insect venom like bee and wasp venom, fire ants, and housefly. And drugs such as analgesics, NSAIDs, antibiotics, biologics, chemotherapeutic agents, contrast media, and proton pump inhibitors. Grading of anaphylaxis. The most widely stated grading of clinical anaphylaxis is Ring and Mesmer, which was given in 1977 for preoperative clinical recognition of anaphylaxis. So grade 1 is there are only skin and mucosal symptoms such as itching, flushing, urticaria, or angioedema, and there are no GI, respiratory, or cardiovascular symptoms. In grade 2, there is skin involvement along with mild abdominal cramps or nausea, upper respiratory tract symptoms such as rhinorrhea, hoarseness, or there could also be dyspnea. In cardiovascular system, there could be tachycardia, more than 20 beats rise in heart frequency from the baseline, hypotension, more than 20 millimeters mercury fall in systolic blood pressure, or arrhythmia. In grade 3, there are skin manifestations along with repetitive vomiting, defecation, respiratory tract symptoms such as laryngeal edema, bronchospasm, and cyanosis. And in cardiovascular system, we could have circulatory shock. In grade 4, we have skin involvement, GI symptoms, along with respiratory or circulatory arrest. The World Allergy Organization, the grading system is adapted from Cox Ellis et al. And Paslequa G et al. So the first two grading of clinical features are not classified as anaphylaxis. Grade 3, 4, and 5 are graded as anaphylaxis. So in grade 3, we have any one of the following symptoms or signs. So lower airway signs such as mild bronchospasm leading to cough, wheezing, shortness of breath, which responds to treatment. GI symptoms such as abdominal cramps or vomiting and diarrhea, or uterine cramps, which could lead to pain in the lower back, plus minus uterine bleeding. In grade 4, we have any one of the following symptoms: severe lower airway clinical symptoms such as severe bronchospasm, which is not responding or worsening in spite of treatment. Upper airway symptoms such as laryngeal edema or stridor. Grade 5, we have any of the following symptoms or signs such as respiratory failure or cardiovascular collapse. Coming to the factors and cofactors, which could worsen anaphylaxis. Infants, here it is difficult to diagnose anaphylaxis as they might have non-specific symptoms and signs of anaphylaxis. In adolescents, there is increased risk-taking behavior, and they are also it is difficult for them to carry anaphylactic auto-injectors. In pregnancy, there is risk from exposure to antibiotics to prevent vertical transmission of infections. And in the elderly, there is increased risk of drug and venom exposure. Concomitant diseases which lead to increased severity of anaphylaxis include asthma, allergic rhinitis, eczema, cardiovascular diseases, psychiatric diseases, mastocytosis, and clonal mast cell disorders.
So here in adolescents, increased risk-taking behavior means that includes alcohol consumption as well as drug intakes. Okay, substance abuse. So they are under the risk. These medications like alcohol and all these things, they also act as cofactor for anaphylaxis. So what it means actually, factors and cofactors, what you mean to say?
So, when we see a patient in the infantile age group, adolescent age group, or pregnancy or elderly, we have to be more at caution for anaphylaxis when we are seeing patients with respiratory distress or the circulatory GI symptoms.
So basically, it is not predictable. Now, from the criteria, from the grading system, what you mentioned, there can be grade 1 to grade 5. So basically, the same food allergen when consumed can present only to you with urticaria. But sometimes the same food allergen can lead to anaphylaxis, severe allergic reaction in the form of anaphylaxis, rash plus other system involvement. So what is there then? The food allergen is same, the patient is same, but the presentation is different. So here comes the role of factors and cofactors. So certain factors and cofactors are there which increases the susceptibility to have severe reactions. Clear? So that means the allergen alone may not cause the patient to have severe reaction, but in presence of these cofactors, the reaction would be severe. Go ahead.
Medications such as beta blockers, ACE inhibitors, NSAIDs, and ethanol. Cofactors that could amplify anaphylactic symptoms are stress, premenstrual status, change in routine, acute illness, or exercise. Coming to the acute management of anaphylaxis, anaphylaxis is a medical emergency. These are the steps advised by the World Allergy Organization. If possible, we have to remove exposure to the allergen. We have to assess airway, breathing, and circulation, and mental status of the patient. Inject epinephrine 1:1000 dilution IM into the anterolateral thigh, that is into the vastus lateralis. We have to position the patient in a supine or a sitting position, whichever offers more comfort. In case of bronchoconstriction, nebulized bronchodilators can be given. In case of upper airway obstruction, nebulized epinephrine can also be given. And second line medications, in case the patient is not responding to the first line medications, are antihistamines, beta agonists, and glucocorticoids. The dose of epinephrine is 0.01 mg per kg body weight per dose. Maximum that can be given is 0.5 milligrams of ADR, 1:1,000 dilution. The dose can be repeated every 10 to 15 minutes if there is no improvement in symptoms.
Just a minute. Yeah, here few points like 0.01 mg per kg. Now, this is an emergency situation where there is no, what you say, there is no time to take the weight of the child. So, do you know any age group criteria or the dose as per the age?
Yes, sir. So, any child above, sir, 3 years and under 3 years of age, sir, we can give 0.15 mg.
So that is
Above,
below 6 years. So 1 year to 6 years.
yes, sir, 1 year to
So
6 year, we
below,
can give.
yeah, below 1 year, it is 0.01 only we have to calculate as per the body weight. But 1 year to 6 years, it is 0.15. Yeah. Then,
From 6 to 12 years, sir, 0.3 mg, and above 12 years, we can give 0.5 mg.
so till 2019, for adolescent and adult, it was 0.5. But now the criteria, there are studies which have shown that for even adolescent and adults also, 0.3 milligram is sufficient. So 0.3 milligram means 0.3 ml. So when we are talking in terms of mg, it is 1:1,000. We are not going to dilute. It is undiluted injection adrenaline, and that is 0.15 ml, 0.3 ml, and 0.5 ml. So when you should give 0.5 ml, if the patient is obese enough, or there was past history of anaphylaxis in the past, or the patient has not responded to the first dose of first dose with 0.3 ml. The next dose you are going to give 0.5 mg. This is for adolescent and adults. Clear? So how many doses can be repeated? You have mentioned doses can be repeated every 10 to 15 minutes.
So we can give 3 doses, and then we have to consider intravenous epinephrine
Infusion.
Yes.
Yeah. So why not intravenous at the beginning only?
So because it is a medical emergency and giving IV boluses can cause arrhythmia.
Yes. So whenever you are going to give IV bolus, it is going to be a diluted one. If you are giving slowly, there won't be arrhythmia, but you are going to waste time in securing a IV line. So whenever you are in any office practice of OPD or ER also, give intramuscular injection and simultaneously you can go for IV assist. Yes, go ahead. Now tell me why adrenaline, why not steroid? You have mentioned hydrocortisone and phenobarbital maleate as second line. Why they should not
Yes.
be the first line?
So because the mechanism of action of ADR here, because of the vasoactive amines, we have to stop the production of these amines, and ADR does that by directly acting on these mast cells to inhibit the activation and degranulation. Also, the alpha receptor agonism leads to peripheral vasoconstriction, and it reduces tissue edema. It also acts on the beta receptors and dilates the bronchial airways, which reduces the wheezing or stridor.
So basically now from the symptomology, we have understood that skin is involved, organs are involved, circulation is involved. So now when you are giving hydrocortisone or antihistamines, their main role, their site of action is the skin, and their action on the organs is less. Whereas epinephrine has got more action on the organs rather than the skin. So the child or the patient is going to die not because of the skin manifestation, it is because of the organ involvement. So that's why adrenaline should be given first. Yeah. Please go ahead.
Yes. Diagnostic tests. Anaphylaxis is a clinical diagnosis. The test that can be done is serum tryptase. Serum tryptase levels peak between 15 minutes to 2 hours with a half-life of 1.5 to 2.5 hours. The reason tryptase is done instead of histamine is because histamine levels peak at 5 minutes and decrease to baseline within half an hour. Over here, normal levels do not exclude anaphylaxis, and the test is repeated after 24 hours of resolution of symptoms.
Why this is being asked that it should be done after 24 hours again?
So we have to see the trend of tryptase.
No, basically, now, first thing, it is a clinical diagnosis. Even if in doubt, you give injection adrenaline first. Now, to prove, somebody will ask you why you gave adrenaline. Was it to anaphylaxis? Now, for further evaluation, you will label the child to have anaphylaxis. You can send serum tryptase. But first thing is to give adrenaline. And then the first sample you are going to collect is around after stabilizing the patient. So say after around 30 minutes. And then you can go for within 1 to 2 or one more sample. And then 24 hours later, one more sample. So approximately 3 samples are advised. So if you don't have so many things, then you can do between 1 to 2 hours of the symptom onset. But why 24 hours? It is not to see the pattern. It is to see that within 24 hours, generally serum tryptase level comes to the baseline. But still, if the after 24 hours also, if the serum tryptase level is high, that tells you that the patient is having some underlying mast cell disorder. So in mastocytosis, you can have elevated tryptase level even if there is no anaphylaxis. Clear?
Yes, sir. The differential diagnosis of anaphylaxis. The common differentials include acute asthma, syncope, anxiety or panic attack, acute generalized urticaria, aspiration of foreign body, cardiovascular like MI and pulmonary embolus, and neurological events such as seizure, cerebrovascular event, postprandial syndrome such as scombroidosis, pollen food allergy syndrome, ingestion of monosodium glutamate, sulfites of food poisoning, uh, disorders where there is excessive endogenous histamine, such as mastocytosis or basophilic leukemia, flushing syndrome, such as perimenopause, carcinoid syndrome, autonomic epilepsy, and medullary carcinoma of thyroid, non-organic diseases such as vocal cord dysfunction, hyperventilation, and psychosomatic episode. And the anaphylactic shock, the DDs, could also be hypovolemic shock, cardiogenic distributive shock, and septic shock. And other DDs include non-allergic angioedema, hereditary angioedema types 1, 2, and 3, ACE inhibitor associated angioedema, systemic capillary leak syndrome, and Redman syndrome, which is associated with vancomycin. We'll now discuss the IAP guidelines. In the IAP guidelines given in 2022, for the diagnosis of anaphylaxis, any one of the three criteria must be fulfilled. So the first criteria is acute onset of an illness with involvement of skin, mucosal tissue, or both, and at least one of the following. It could either be respiratory compromise or circulatory compromise. The second criteria is two or more of the following that occur acutely after exposure to a likely allergen for that patient. Uh, Along with involvement of skin or mucosal tissue, respiratory compromise, circulatory compromise, or persistent GI symptoms. And the third criteria is acutely after exposure to a known allergen for that patient. There is reduced PP, defined as low systolic blood pressure for that age, or more than 30% decrease in systolic blood pressure from baseline.
So this is as per the old NIAI classification, and this is more practical. So now still we are using this only. Fine. So here, any child, first criteria is any child, no history of allergen involvement. So in the second criteria, what I mentioned is exposure to likely allergen. And the third criteria, it is to a known allergen. So you can see it is getting narrowed down. So if it is a known allergen, only one manifestation of hypotension labels the patient to have anaphylaxis. Clear?
Yes, sir.
Yeah.
If the patient is satisfying any of the three criteria, we label the child with anaphylaxis. So the initial management that is done within the first minute of presentation is we have to keep the patient supine. This is done to increase the preload. Sitting, if there is respiratory symptoms, nausea or vomiting, we have to assess airway, breathing, and circulation. Provide oxygen at 10 to 15 liters per minute by a non-rebreathing mask. If there is respiratory distress or shock, and we have to identify and remove the allergen if possible. We have to administer the first dose of IM epinephrine at 0.01 mg per kg per dose at the anterolateral aspect of thigh, and this can be repeated at 5 to 10 minute intervals as needed. In the next 5 to 10 minutes, if there is respiratory distress, we have to place the child in a sitting position. We have to provide HFNC and prepare for intubation. If there is stridor, we have to nebulize with ADR at 0.5 ml per kg. Maximum is 5 ml. If there is wheezing, we have to nebulize with salbutamol at 0.15 mg per kg. If there is circulatory collapse or decreased perfusion, we have to again place the child in a supine position. IV or IO access is to be established, and the first bolus of NS, normal saline, is given at 20 ml per kg by IV or IO route by rapid push and push technique. In the next 5 to 10 minutes, if there is no improvement in symptoms, we have to give the second dose of IM epinephrine and second dose of salbutamol and nebulized epinephrine as needed. And if already not achieved, we have to obtain IV or IO access and prepare for difficult intubation. The second bolus of normal saline at 20 ml per kg can still be given if the child is hypotensive, and we have to alert the critical care team. The next 10 to 20 minutes, if there is no improvement still, we have to give the third intramuscular dose of epinephrine. If respiratory distress is still present, we can give third doses of nebulizations as needed and proceed for intubation. If the child is still hypotensive, we have to start the child on IV epinephrine 1:10,000 dilution at 0.05 mics per kg per minute and titrate by 0.02 mics per kg per minute till there is effect. And we have to transfer the child to PICU within 20 minutes of arrival to the ER. If there is still no improvement in the condition, we have to start IV norepinephrine infusion if there is persistent hypotension at 0.05 mics per kg per minute and titrate by 0.02 mics per kg per minute up to effect. IV glucagon bolus can also be given if there is persistent anaphylaxis or the patient is on beta blockers, because if the patient is on beta blockers, he won't respond to our beta agonist therapy. This is given at 20 to 30 mics per kg per dose, maximum 1 milligram over 5 minutes, followed by 5 to 15 mics per minute, titrated till achievement of clinical effects. And then we have to manage as per PICU protocol. Monitoring. There are two reactions of anaphylaxis which we have to be careful about. One is protracted anaphylaxis. Over here, the reaction lasts for hours to days without resolving completely. There are severe persistent anaphylactic symptoms for 24 to 36 hours despite aggressive treatment. There is also biphasic anaphylaxis. This is over here, there is an initial reaction followed by a symptom-free period of an hour or so, and then there's another return of symptoms without exposure to the allergen. Half of these biphasic reactions occur within 6 to 12 hours. Monitoring of vitals along with respiratory symptoms should be done over minutes during the first 30 minutes and then hourly for the next 24 hours and then 2 hourly for the next 48 hours. Follow-up of patient should be done for at least 4 hours after the last intramuscular epinephrine injection, and in severe hospitalized cases for a minimum of 3 days.
So here now you should remember, now in this case the symptoms were mild, they responded without adrenaline and was discharged within 4 hours. So basically, for all practical purposes, always keep the child for at least 12 to 24 hours, because the chances of having biphasic anaphylaxis is more. So the child will come out of the anaphylaxis episode after a gap of say 4 hours or 6 hours. Again, the symptoms may come at home, and that time again the easy to give means the adrenaline will be delayed. So always keep a child who had anaphylaxis at least for 12 hours to 24 hours.
Yes, sir. Following are the indications of hospitalization. If there is tachycardia or there is hypotension, if there is stridor, wheeze, or tachypnea, for 1 to 5 years, more than 40 per minute, more than 5 years, 30 per minute, and more than 10 years, 20 per minute. Saturation is less than 95% on room air. There is history of severe protracted anaphylaxis. There are comorbidities such as asthma, arrhythmia, systemic mastocytosis, or the child lives in a remote area, or they present late in the evening. Discharge from the hospital. If it is a simple episode and it's not very severe, you can discharge after a minimum of 4 hours after the last intramuscular injection of epinephrine. And the discharge advice includes antihistamines, cetirizine 5 to 10 mg once daily for 3 days, and corticosteroids are optional. You can give oral prednisolone at 1 mg per kg, maximum up to 75 milligrams daily for 3 days. In follow-up, we have to advise the patient's parents on allergens and suspected allergens. We have to educate them on the use of EpiPen. It is costly and difficult to obtain EpiPen in India. Hence, home-prepared syringes of epinephrine can be used. We have to counsel regarding identifying early signs and plan of action in case another attack happens. Follow-up with allergy specialists is done after 4 weeks for allergy testing.
Why is it so? Why not immediate follow with an allergist?
So, because the result could be falsely negative if we do a skin prick test because the mast cells have degranulated in the anaphylactic episode.
Yeah, so because all the histamines, there are no histamines left over in the mast cells. So because of the severe reaction, so that's why we allow the mast cells to get replenished with the histamine again over a period of 3 to 4 weeks. So only skin prick test can be done after 4 weeks of the episode. But if parents insist that no, doctor, we want to know the allergen, what is involved in this case? So what is the option then?
Sir, can you repeat the question?
So if parents are insisting that we cannot wait for 4 weeks, we want to know what was the culprit agent. So do you have any test which can tell you immediately after anaphylaxis episode?
So we can do an IgE, a specific allergen IgE testing.
Yes. So serum specific IgE for particular allergens you can go for. That can be done at any point of time.
Yes, sir.
Yeah.
So, coming to the newer advances, ARS Pharmaceuticals based in US have completed their clinical study for intranasal epinephrine spray, that is Neffy, and it is expected to get FDA approval by the end of 2024. There is also sublingual epinephrine preparation known by Anafilm. It is a sublingual preparation which has completed phase 3 of study and yet pending FDA approval.
So basically, patient training is very important so that they should recognize themselves when they are landing up in the anaphylaxis episode next time. So they should be able or they should be trained to give intramuscular injection by their own, or in our pediatric patients, parents should be taught to how to give intramuscular injection. Before they reach to the ER, they should give first dose of injection adrenaline at home only. Now, by having these newer advances, that will make it simple for parents to give epinephrine. So long way we need to have, because still we don't have EpiPen. So auto injectors are not available in our country. Still we are giving or prescribing patients to have pre-filled adrenaline syringes.
Yes, sir.
Yeah.
So
So
that is the end.
yeah, it was a good presentation, Radhika. So any
Thank
doubts from the audience or the other residents who are there in the presentation?
I think Radhika, it
Radhika
was a
will be
very good
happy to share.
presentation. Very good presentation, and Dr. Patra, you have done a wonderful job. And I think majority of the questions you have already discussed during the time of discussion. Just to sum up the things, so anaphylaxis is something which is uh, less suspected, and it is considered that probably it is a rare event, so it is often missed. So the criteria which have been revised, or the latest criteria, they are made in such a simple manner so that we should suspect more, we should even overemphasize that, we should even overdiagnose it, so there is no problem. But if we are missing a simple case, then at that particular time, that could be life threatening for that particular patient. So it is always better to, you can say, like, overdo in case of anaphylaxis rather than doing underdoing. The important thing is, which you have highlighted about the criteria, the other important thing is that the ideal recommendation for admission should be till the time this biphasic and the protracted period is gone. So theoretically, it should be 3 days or 72 hours, but definitely 24 hours it should be there, and we need to take care of that. And adrenaline is the first choice drug for anaphylaxis, which you have already mentioned. So I think you have beautifully covered all those topics, everything here. And this particular child, like, he has followed up with me So this child has actually got the shrimp allergen positive, and probably because the shrimp allergen positive and the cofactor of exercise soon after that, so which made him like a food dependent induced anaphylaxis in this particular child. So otherwise, rest of the things were fine in this particular child. So I think a very nice presentation. Thank you very much, Dr. Vikram, and thank you very much, Dr. Radhika, for doing this presentation for us. Thank you.
Thank you. Thank you. So basically, in this case, there was the child already had taken prawns in the past, but this time only he developed rash, right? Because there was exercise which played as cofactor in this case. So this falls. This is not only a simple case of anaphylaxis. This we call it as food dependent exercise induced anaphylaxis. Anyway, thank you, Radhika, for that excellent presentation. All the best.
Thank you, sir.